Ladies and gentlemen, today we delve into the fascinating realm of anemia, a condition characterized by a deficiency in the quantity or quality of erythrocytes, the red blood cells responsible for carrying oxygen throughout our bodies. Anemia is a widespread and multifaceted condition that affects individuals of all ages and backgrounds. As medical professionals, it is imperative that we understand the nuances of this disorder to provide our patients with the best possible care. Slide 2, Definition and Classification. Let us begin by defining anemia. It is a deficiency in the quantity and/or quality of erythrocytes, leading to a decreased oxygen-carrying capacity of the red blood cell mass. The term hematocrit, derived from the Greek roots hemat meaning blood, and crits meaning to judge or gauge, is a measure of the proportion of red blood cells in the blood. Anemia can be classified in two ways, by etiology or pathology, and by morphology. The etiological classification distinguishes between quantitative and qualitative anemias, while the morphological classification considers the volume and hemoglobin level of the red blood cells. Slide 3, Signs and Symptoms. Anemia can manifest in a variety of signs and symptoms, including fatigue, pale skin, a rapid or irregular heartbeat, shortness of breath, chest pain, dizziness, cognitive problems, cold extremities, and headaches. These symptoms are a direct consequence of the body's inability to effectively transport oxygen to tissues and organs. It is crucial to recognize these signs and symptoms, as they can alert us to the presence of an underlying anemia, prompting further investigation and appropriate treatment. Slide 4, Quantitative anemia. Quantitative anemia is characterized by a decreased red blood cell mass. It can be further divided into relative anemia, caused by a dilution effect, such as during pregnancy or hyperhydration, and absolute anemia, which can arise from production defects, maturation defects, survival defects, or sequestration. In quantitative anemia, the reticulocyte count, a measure of newly formed red blood cells, can provide valuable insights into the underlying cause. A low or normal reticulocyte count may indicate a production defect, while an increased count may suggest a survival or maturation defect. Slide 5, Qualitative anemia. Qualitative anemia, on the other hand, involves abnormalities in the development of the heme or globin components of hemoglobin. Examples of qualitative anemias include iron deficiency anemia, vitamin B12 deficiency anemia, folic acid deficiency anemia, hemoglobinopathies such as thalassemia, and marrow failure disorders like aplastic anemia. In these cases, the morphology of the red blood cells can provide valuable diagnostic clues. For instance, microcytic and hypochromic red blood cells are characteristic of iron deficiency anemia, while macrocytic red blood cells may indicate a vitamin B12 or folic acid deficiency. Slide 6, Diagnosis of anemia by morphology. The diagnosis of anemia often begins with a thorough examination of the red blood cell morphology. A low hemoglobin, hematocrit, and red blood cell count are initial indicators of anemia. The mean corpuscular volume, or MCV, a measure of red blood cell size, can further differentiate between microcytic, normocytic, and macrocytic anemias. The reticulocyte count plays a pivotal role in determining the etiology of the anemia. A normal or increased reticulocyte count may suggest a hemolytic process, while a low count may indicate a production or maturation defect. Slide 7, Corrected reticulocyte count, CRC, or reticulocyte production index, RPI. In cases of anemia, the reticulocyte count, which is reported as a percentage, can be artificially elevated due to the reduced number of circulating red blood cells. To account for this, we calculate the corrected reticulocyte count or reticulocyte production index. This adjustment involves dividing the reticulocyte count by the patient's hematocrit and multiplying by the normal hematocrit value, typically 45%. In severe anemia cases, an additional correction factor may be applied to account for the presence of immature reticulocytes, known as polychromatic red blood cells. A reticulocyte production index below 3% is considered indicative of ineffective erythropoiesis, or red blood cell production, in the setting of anemia. Slide 8, Morphological approach to anemia diagnosis. Let us now delve into the morphological approach to anemia diagnosis, a systematic method that guides us through the various possibilities based on the red blood cell indices and reticulocyte count. If the MCV is low, indicating microcytic red blood cells, and the MCH, or mean corpuscular hemoglobin, is also low, we must consider iron deficiency anemia, lead poisoning, or chronic disease as potential causes. Slide 9, Iron deficiency anemia. Iron deficiency anemia is the most common cause of microcytic, hypochromic anemia. Clinical findings such as a sore tongue, spoon-shaped nails, and pica can provide additional clues to this condition. The evaluation of iron deficiency anemia involves assessing serum iron levels, total iron binding capacity, ferritin levels, and potentially a stool guaiac test to detect occult bleeding. Slide 10, Iron Studies. To fully understand iron deficiency anemia, we must delve into the intricacies of iron studies. The serum iron level reflects the amount of iron in the bloodstream, while the ferritin level indicates the body's iron storage capacity. The total iron binding capacity, or TIBC, measures the available sites for iron binding on transferrin, the iron transport protein. The percentage of transferrin saturation, calculated from the serum iron in TIBC, provides further insight into the body's iron status. By interpreting these values in context, we can differentiate between iron deficiency, iron overload, and chronic disease states. Slide 11, Lead poisoning. Lead poisoning, particularly in children, can also present with microcytic, hypochromic anemia. Symptoms may include irritability, loss of appetite, weight loss, abdominal pain, learning difficulties, and, in severe cases, encephalopathy. Screening for lead poisoning involves measuring blood lead levels, particularly in high-risk populations. Radiographic findings, such as lead lines on long bone X-rays, can also raise suspicion for lead toxicity. Slide 12, Chronic disease anemia. Chronic diseases, such as cancer, autoimmune disorders, and infections, can also result in anemia, often normocytic or microcytic in nature. In these cases, the serum iron in TIBC may be low, while the ferritin level remains normal or elevated, reflecting an inflammatory state. The evaluation of chronic disease anemia should focus on identifying and treating the underlying condition, as well as monitoring for potential complications. Slide 13, Hemolytic anemia. Moving on to normocytic, normochromic anemias, we encounter hemolytic anemia, characterized by increased destruction or shortened lifespan of red blood cells. This can be caused by mechanical stress, heat, red cell membrane disorders, toxins, immunohemolysis, hemoglobinopathies, or enzyme abnormalities. In hemolytic anemia, the reticulocyte count is typically elevated, reflecting the body's attempt to compensate for the increased red blood cell destruction. Additional tests, such as bilirubin levels, lactate dehydrogenase, and haptoglobin, can aid in the diagnosis and differentiation of hemolytic anemias. Slide 14, Hemolytic anemia testing. The evaluation of hemolytic anemia involves a comprehensive panel of tests. Elevated indirect and direct bilirubin levels, along with increased lactate dehydrogenase, can indicate hemolysis. A decreased haptoglobin level, a protein that binds free hemoglobin, is another hallmark finding. In certain cases, such as thalassemia or sickle cell anemia, a hemoglobin electrophoresis may be warranted to identify specific hemoglobin variants. The Menser index, which considers the MCV and RBC count, can help differentiate between iron deficiency anemia and thalassemia. Slide 15, Acute blood loss anemia. Acute blood loss, whether due to trauma, surgery, or gastrointestinal bleeding, can result in a normocytic, normochromic anemia with an initially elevated reticulocyte count. In these cases, a thorough physical examination and appropriate imaging studies, such as an abdominal CT scan, may be necessary to identify the source of bleeding. Slide 16, Chronic disease. Slide 16, Chronic disease. In addition to normocytic, normochromic anemias caused by acute blood loss, chronic diseases can also result in this type of anemia. Malignancies, such as cancer and multiple myeloma, as well as autoimmune disorders, can lead to anemia through various mechanisms. The evaluation of chronic disease-associated anemia often involves assessing serum iron levels and total iron binding capacity. In these cases, the serum iron may be decreased, but the TIBC can be normal or decreased due to altered protein production. Ferritin levels, however, may remain normal or elevated, reflecting an underlying inflammatory state. Slide 17, Macrocytic anemia. Let us now turn our attention to macrocytic anemias, characterized by larger than normal red blood cells. These anemias can be caused by a variety of factors, including vitamin B12 or folate deficiencies, hypothyroidism, myeloproliferative disorders, liver diseases, and certain medications. In macrocytic anemias, the reticulocyte count can provide valuable diagnostic information. An elevated reticulocyte count may indicate a reactive process, such as reticulocytosis, while a normal count may suggest a vitamin B12 or folate deficiency, or other underlying conditions. Slide 18, Reticulocytosis. Reticulocytosis is a condition characterized by an increased number of reticulocytes, or immature red blood cells, in the bloodstream. This can occur in response to various stimuli, such as hemorrhagic episodes or the restoration of proper nutrition to a previously nutrient-starved bone marrow. The reticulocyte count typically peaks within 4 to 7 days following a hemorrhagic event. If the count exhibits a second peak or fails to decrease, it may indicate ongoing or prolonged bleeding, warranting further investigation.